Good afternoon, everybody. Thank you for joining. This is the ONC Health IT Certification Program Developer Roundtable. My name is Josh Shapiro, and I'm with Capital Consulting, and I'll be assisting with the logistical support for today's session. You can ask questions by clicking the Q&A button at the bottom of your screen, and you can also ask questions verbally by clicking the raise hand function under the reactions. We'll go ahead and unmute your line once your hand is raised. Additionally, we ask that you select the speaker view option located at the top right of your Zoom platform. This will allow you to see the speaker as they present or share information. If you need any technical assistance throughout the webinar, please click the chat icon at the bottom of your screen, type your question into the chat, and myself or one of the other hosts will be happy to help you solve your problem. And if you do need, finally, sorry about that, today's session is being recorded, just so you are aware. And if you need closed captioning, please click on the CC icon at the bottom of your screen. The materials contained in this presentation are based on provisions contained in the 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. And please note that other federal, state, and local laws may also apply. This communication is produced and disseminated at the U.S. taxpayer expense. And I will now turn this webinar over to the Director of the Certification Program, Robert Anthony.
Thanks, Josh. Welcome and good morning and afternoon to everybody, depending on where you are joining us from. This is our quarterly ONC Health IT Certification Program Developer Roundtable. Let's go to the next slide. As Josh noted, we are covering things that are by and large contained within federal regulation. We do try to do everything that we can to make sure that everything here is accurate, but of course, anything that we do here is not superseded or does not supersede what is in federal regulation. So please, you will see at the end of this a link to our website where many of the federal regulations and published resources are. Encourage people to go and take a look at those. Next slide. We have a nice full agenda for everybody today. As many of you have probably noticed, we have published the 2024 approved standards as part of the standards version advancement process. Please take a look at the Health IT Buzz blog that is on ONC today. That will link you to where the current standards are. We'll also have some links later in this document. We're going to have some folks that are going to go through and look at the standard version advancement process as a whole, and then look specifically at what is in the 2024 approved versions. And then we're going to spend a little time at the end to talk about decision support interventions. For those of you who are or not aware, B11 is a new certification criteria for decision support intervention that replaces the A9 clinical decision support certification criterion. We have new requirements. Some of them are very different around transparency related to those DSIs. We have some new resources out. We're going to cover some of the highlight big areas that you need to know about. And if we have some time, we'll try and do some Q&A later on this as well. Next slide. So today's speakers, we're going to have Sean Spurlock from Certification and Testing Division, who's going to go through and do an overview first of how the SBAP process works. For those of you who are not familiar with it, it is, of course, a voluntary advancement process. Liz Turi, who is from our Standards Division, is going to go through and talk about this year's 2024 approved standards that can be used shortly as part of that SBAP process. Then we will transition to talking about B11 DSI, and Jeff Smith, who is the Deputy Director of Certification and Testing, and Nikki Hayes, who is part of our C&D team, will be going through and talking about DSI requirements and those resources. So thank you again. Please do put any questions into the Q&A. If we don't manage to get to those, a reminder that we do have a health IT portal that people can go and submit questions to and be answered by the team. Since we get the question all the time, and we will go ahead and repeat it to others as we go through this, but yes, this is being recorded. Yes, it will be put on our website. Yes, the slides will be made available. If you go to our healthit.gov website and navigate to the certification testing program, there is a program resources section that this will eventually appear in. Next slide. I turn this over, I believe, to Sean to talk about SVAP as a whole.
Right. Thank you, Rob. So hello, everyone. As Rob said, I'm Sean Spurlock from the ONC Health IT Certification Program. Today, I will be providing a brief overview of the Standards Version Advancement Process, or SVAP, how it works, and how it can be leveraged. Following my presentation, my colleague Liz Turry will go over the 2024 approved SVAP standards, which, as Rob said, were announced this morning. Next slide, please. So what is SVAP and why is it important? The SVAP flexibility was introduced as part of the real-world testing condition and maintenance of certification requirement of the 21st Century Cures Act as a means for developers to voluntarily incorporate newer, more advanced versions of standards into their certified health IT modules without the need for a formal rulemaking process, which can be a very long and time-consuming endeavor. Notice, as Rob said, I did say this is voluntary flexibility. Developers are not required to take part in the SVAP process. So the SVAP cycle, it's an annual cycle, and it provides the certification program with predictable and timely approach that allows us to maintain pace with standard development efforts throughout the health IT industry. It also reinforces ONC's commitment to interoperability as approved standards reflect insights that we've gained from real-world implementation and use of health information technology. Next slide, please. As I said, SVAP is limited to standards adopted in the certification criteria that meets the real-world testing condition and maintenance of certification. The next slide will contain what those certification criteria are. I'm sorry, if you go back to the previous slide, please. Thank you. Developers can incorporate SVAP standards into both new and existing certification. This ensures that updated standard versions are able to be effectively implemented into health IT modules. Developers who choose to leverage SVAP standards are required to include them in their annual real-world testing plans and their accompanying results. And the link at the bottom links to the certification program's SVAP page, which provides more information on the SVAP process as it relates to certification. And as a reminder, as I will say multiple times, that these slides will be made available, including all the links following today's show. Next slide, please. So shown here are all the applicable real-world testing criteria. I'm not going to go through each of them, but I did want to point out how they are categorized. So we have care coordination criteria, clinical quality measures, patient engagement, electronic exchange, public health, and API or application programming interfaces criteria. Once these slides are made available, each of these criteria link to their respective certification companion guide or CCG, which will provide you with more detailed information on each criterion and their associated certification requirements. Next slide, please. So as I said, the use of SVAP is strictly voluntary. Developers choosing to incorporate approved SVAP standards into their modules can do so on newer existing certifications. For developers updating existing certifications, they are required to provide notice to their ONC ACV as well as all effective customers expressing their intent to update their module to the newer approved standard version. Any expectations for how the standard will impact the module's interoperability or functionality, and whether or not the developer intends to support or to continue to support certificates for the existing Certified Health IT module. Both new and existing certifications that are leveraging SVAP are required to conform to all applicable certification requirements with the SVAP standards that they are leveraging, which, as I said, includes updating their annual real-world testing plans and their accompanying results. Next slide, please. So depicted to the right is a flow chart of the annual cycle and how it works. The cycle publicly begins each year with the opening of the public comment period and concludes when the SVAP standards become effective and available for use in the certification program. As I said, the approved standards were released this morning, and they will be available for use in the certification program following the 60-day delay period, which will be August 19th of this year. So just going through the graphic to the right. So ONC considered all available updates to applicable standards, which we then release for the public comment period. Once that public comment period closes, we internally review all comments received on the standards, and then the national coordinator makes his determination of which standards are going to ultimately be approved for a given SVAP cycle, which are then announced, and then, as I said, following the 60-day delay period, are available for use in the certification program. Next slide, please. So for the 2024 SVAP cycle, the public comment period opened on January 16th and closed May 21st. The SVAP standards were announced this morning, which will become effective on August 19th. The 2025 SVAP cycle will publicly begin at the commencement of the public comment period, which will open sometime in January 2025 and will close May 2025. More information on the actual process itself is linked to the right. Next slide, please. So we received a fair amount of questions regarding previously approved SVAP standards. A version of an adopted standard approved for use during any SVAP cycle remains available until a newer SVAP version of that standard is approved. For example, if a standard was made available through the 2023 SVAP process and was not updated during the 2024 SVAP process, the 2023 SVAP version is still available. However, if the 2024 SVAP process updated that given standard, then the 2023 version would no longer be available for use, and the 2024 SVAP standard would be the new standard available for use. Developers who have previously leveraged SVAP are not required to continue advancing to newer SVAP versions. So if you, for example, updated a module during the 2022 SVAP cycle, you are not required to continue updating to the 2023-2024 FEDRA cycles. Any certification that was based on a previously adopted SVAP standard, regardless if that standard has been updated in future SVAP cycles, will remain valid within within the certification program. And linked below on the bottom of this slide is the complete list of all SVAP standards for all previous SVAP cycles. Next slide, please. And this page just contains SVAP resources. The first is just the certification program's SVAP fact sheet, which includes an overview of the SVAP process as it relates to the certification program, as well as the 2024 SVAP standards. Our SVAP certification page, again, includes an overview of the process, but also includes a complete list of all SVAP standards through all previous cycles. The SVAP process page, link there, provides information on the annual process, including a list of eligible standards and their versions for consideration. The ONC standards bulletin allows for developers and all interested parties to view and sign up for stakeholder alerts that includes updates on the ONC Health IT Standards Initiative, which includes SVAP standards. And we also, not just SVAP, but a variety of certification program resources are linked at the bottom bullet. And here you can expect resources that will not only help you through the SVAP process, but also all things related to health IT certification. Next slide, please. I will now pass it over to my colleague, Liz, to go over the approved standards for 2024.
Thank you. Next slide, please. So after reviewing the comments from this year's comment period, we have 9 areas for approved standards, and we'll go through them in a little more detail. These are the 9. You'll note that both CMS QRDA 1 implementation guide and CMS QRDA 3 implementation guide are both noted under number 4. Next slide, please. All right, so for our annual updates, these are based on USCDI and CMS. The one thing I want to call out here is that we previously had both the CCDA templates for clinical notes as well as the companion guide. This year, HL7 has consolidated both of those into the implementation guide, CCDA templates for clinical notes edition 3. This replaces both the templates and the companion guide that was recently previously been used. You'll also note here that we have both the current standard that is expiring on January 1st, as well as the standard that's required by December 31st. Again, noting that CMS QRDA 1 and QRDA 2 are both noted in the C3 guidelines. Next slide, please. These are the public health criteria that we have updated to within SVAP. There's nothing particularly to note here, just that they have been updated, but no additional things to keep in mind. Next slide. And the last are additional interoperability and accessibility standards. We are including the Smart Application Launch Framework Implementation Guide v2.2, which was recently published on April 30th. And then we are doing an update to our WCAG standard reference to 2.2. And that's all I have. Next slide.
All right, moving on in the agenda. Good afternoon on the East Coast, and I guess still good morning to everyone else. We're going to go through a series of slides focusing on the decision support intervention certification criterion at B11. And my colleague, Nikki Hayes, is going to walk you through aspects of a resource guide that we recently published. So if you can go to the next slide, please. In May of this year, so just about a month ago, we published a resource guide, version 1.0, which really tried to distill several dozen pages of proposed rule and final rule preamble, including several comments that we received and responses to those comments, as well as included clarifications that we have made and included as part of several CCGs on the certification website under the B11 criterion into a single document. And we tried to present information in a way that would really walk developers and other interested parties through important aspects of the B11 criterion. I think the final document ended up being around 28 pages, and we highlighted key definitions, provided some examples of what a predictive DSI is, as well as described evidence-based DSIs, and then highlighted several important functionalities. For the remainder of the slides that we've got, we're going to highlight key aspects of the decision support resource guide. And then if there's any time at the end, we're happy to take questions, and you can use the questions box as we go along, and we'll try and answer those as we can. I will try to put here into the chat box link to the resource guide, just in case you want to follow along at home. And as has been mentioned several times, these slides and related hyperlinks will be available to you after we get this posted to our certification website. So now I'm going to hand things off over to Nikki, who will walk you through kind of a high-level agenda, and then hopefully, like I said, we'll leave you with a link where you can ask additional questions if we don't have enough time by the close of this session. So Nikki, you want to take it away?
Thank you, Jeff. Hello, everyone. Next slide, please. So this is just our agenda for the DSI. We're going to go through definitions and concepts, an overview of required capabilities for B11, timelines, and then again, if we have time at the end, we'll do a Q&A session. Next slide, please. And next slide. So this first slide, these first set of slides will be key definitions and concepts. One of the main things we want to talk about here is predictive support interventions. We finalized a definition for predictive support interventions, or predictive DSI, sort of a three-pronged approach to the definition. It's technology that supports decision-making based on algorithms or models that derive relationships from training data, and then produces an output that results in prediction, classification, recommendation, evaluation, or analysis. The scope of our definition is broad. It is use case inclusive. It's risk independent and developer agnostic. We believe it's important to understand the reasons behind the definition is we wanted to cast a wide net, as there may be technologies out there that perhaps should be considered predictive DSI, but that doesn't mean that all predictive DSI technologies are going to be subject to our requirements at B11. Pardon me. We did include fairly simple and straightforward risk calculators, as well as the more complex large language models and other generative AI. The definition applies equally despite the use case and despite the level of risk. Next slide, please. Few key concepts and definitions. So for evidence-based DSIs, those are only DSIs that are actively presented to users in the clinical workflow to enhance, inform, or influence decision-making related to the care a patient receives, and that do not meet the definition for predictive DSIs at section 170.102. And sort of when we're talking about the actively presented piece, that stands in contrast to decision support that initiates an action without a user's knowledge or occurs outside a user's normal workflow. Another concept or definition we're looking at is our source attributes. Oh, did the screen go blank, or is that just me? Oh, there we go. Okay, source attributes. Source attributes are categories of technical performance and quality information related to how evidence-based DSIs and predictive DSIs were designed, developed, tested, evaluated, and should be used. Another important concept is the FAVES concept. This is a conceptual model for decision support intervention quality. Each source attribute and risk management requirement contributes to a better understanding of whether a predictive DSI is fair, appropriate, valid, effective, and safe. Again, our FAVES concept. Intervention risk management, or else We also refer to it as IRM practices. It's a set of activities used to analyze and mitigate different kinds of risks associated with predictive DSIs. Intervention risk management practices include policies and controls for governance and data management related to predictive DSIs. Next slide, please. Excuse me. Some additional key concepts, and some we've received a few questions through our JIRA portal. The supplied by configuration nexus. So in B11, the regulation text states supplied by the health IT developer as a part of its health IT module. This is an important concept. So certified health IT developers can supply evidence-based DSIs and predictive DSIs. They create themselves. They can also supply DSIs created by other parties. Again, supplied by means that the certified health IT developer takes stewardship and accountability for that specific evidence-based or predictive DSI within its health IT module. Another concept we sort of hone in on is as part of its health IT module. We've had a few questions about this as well. This means the developer of certified health IT has explicitly offered or provided its customers the technical capability to use or support a predictive DSI, regardless of whether the predictive DSI was developed by the developer of certified health IT or by other parties. Supplied DSIs can comprise clinical, administrative, operational, and use cases. Next slide, please. So here we're going to go over, next we'll go over an overview of required capabilities at B11. Next slide, please. All right, so the decision support configuration. Health IT module certified to B11 must enable a limited set of users to configure evidence-based as well as predictive DSIs based on the user's role. There must be interventions based on reconciliation of patients' meds and allergies. Patients' meds, allergies and tolerances and problems as part of the transition of care or referral summary. And users must be able to provide electronic feedback data for evidence-based DSIs. The health IT module must support that feedback data regarding the intervention, the action taken, user feedback provided, user date, and location. The module must also make that feedback data available to a limited set of identified users for export in a computable format. Next slide, please. So some additional clarifications on the feedback loops. Only evidence-based DSIs actively presented to users in a clinical workflow must be supported by that feedback loop functionality. The B11 certification requirements do not specify when or how the feedback should be gathered. Rather, the certification is intended to be flexible to enable a user to provide feedback in a manner appropriate to their workflow. There is nothing in the certification program that requires users to provide the electronic feedback. Developers of health IT modules certified to B11 must allow a specific group of users, and this specific group of users is determined by the user organization. Must allow those users to access and import feedback data in a computable format. However, the health IT developer is not required to export that to all users. Instead, the option to export feedback must be available to a specific group of users that's identified by that customer. Next slide, please. So decision support selection. The health IT module must enable a limited set of identified users to select or activate evidence-based as well as predictive DSIs. We did not list out the evidence-based and predictive DSIs, use cases that developers must support. Instead, the program establishes a scope of DSIs that must be supported based on data elements found in US core data for interoperability. Evidence-based DSIs within the program that must be supported include those that use any of the following USCDI-based elements. And you'll see those listed here with problems, meds, allergies, etc. Conversely, evidence-based DSIs that do not use any of these data elements listed do not need to be supported and are not subject to B11 requirements, such as the feedback loops functionality. Predictive DSIs within the scope of the program that must be supported include those that use any USCDI data element. Next slide, please. Some additional clarifications on the DSI selection piece. So we did not specify a standardized configuration to enable selection of evidence-based as well as predictive DSIs. Developers must support the ability to select predictive DSIs, whether they're self-developed by the customer or by other parties. Evidence-based DSIs that include any demographic element listed at section 170.315 A5 numerat I must be supported. You'll see there, these are different in scope and may require the use of different vocabulary standards than the USCDI data elements listed under the patient demographics information data class versions of these data concepts. Modules must support evidence-based DSIs that use concepts at 170.315 A5I and should adhere to the standards and requirements in that same section. And you'll note there's a link here at the bottom of this slide that links directly to our resource guide in the Appendix A, which it's a nice graph that sort of lays out those USCDI elements sort of in a much more digestible format. Next slide, please. So the source attribute support. All health IT modules certified to be 11 must support 13 source attribute fields for evidence-based DSIs, and they must support 31 source attribute fields for predictive DSIs. The developer is not responsible for the content of the source attribute fields. However, they must make space or they must support those source attribute fields for evidence-based and predictive DSIs. Again, this goes back to the supplied by concept. A developer is responsible for the content if the decision support intervention is supplied by that developer of certified health IT. Developers will need to work with their customers to determine the best format and structure of source attribute information and format. Next slide, please. So here we have listed, these are the 13 source attributes for evidence-based DSIs. You'll notice there on the left, there are 4 source attributes. These are consistent with our A9 CDS criterion. And then when you see on the right, 5 through 13, those are the additional 9 source attributes that are related to specific data. This allows users to know when this information is being used in their decision support intervention, and the user can make the determination whether the data elements are appropriate for use in the DSI tool, going back to that concept of transparency. Users should have access to the data information within the 13 attributes. And clinicians and health systems will also benefit knowing this information. I think we have a graphic that also points out that the information on the left is previous CDS information and the information on the right is new. We'll click that next, please. Perfect. All right. So some additional clarifications on developer supplied evidence-based DSI source attributes. When a DSI is not based on published clinical guideline, but local needs, the bibliographic citation and the developer of the intervention may be the same. When information is only available through published literature, developers may indicate source attribute information is not available and that it cannot be replicated. We listed here for source attributes at this citation 17035. The use of the data element is required to be disclosed. Developers are not required to indicate when one of these data elements is not used. The program requires developers indicate when an evidence-based DSI uses patient demographic, social determinants of health, and health status assessment data elements, consistent with dates established in section 170.213. Health IT modules must indicate when USCDI version 1 data elements are used in evidence-based DSIs up to and including December 31st, 2025. Beginning January 1st of 2026, Health IT modules must indicate when USCDI version 3 data elements are used. Next slide, please. So now we're going to look at the 9 predictive DSI source attribute categories. Sort of as we drill down, the top row, 1 through 3, that is what the intervention does, how it should be used, and how it should not be used. Second row, 4 through 6, is how it was developed, including input features, processes used to ensure fairness, and external validation of the model, if any. And then that last row, 7 through 9, is how it performed. It's a quantitative measure, how it is being maintained, and how it is being updated. Next slide, please. I know this slide is rather busy. There's an extensive amount of text here, but this is how we emphasize source attribute information that's most frequently included in existing reviewed reporting guidelines, meaningful and interpretable in the context of health IT users and developers, focused on health equity, fairness, and identifying issues of bias. Pardon me. What we did, we analyzed and drew from more than a dozen widely accepted and used reporting guidelines. Within the 9 categories of source attributes, we specified 31 specific types of information listed here. Again, it's quite a bit of information, but we'll take a look at just one of the concepts here. Number 2 is the purpose. What is the purpose of the intervention? And the source attributes we're looking at are intended use, intended patient population, intended user, and intended decision-making role. Each of these items we described in the proposed rule as things that should be included in reporting these source attributes. The aim is to be more specific and narrower in the types of information that are required to be reported. The goal of the source attribute list is to establish a consistent industry-wide foundation upon which others may standardize or customize. Next slide, please. I think we've got a little animation in here. Okay, and I apologize. I think the slides are going to sort of double. Perfect. You'll notice here on this same slide, we have information, source attributes that are highlighted in yellow. And we have, looks like number 6 and number 9 are also marked by asterisks. These are the source attributes that we recognize may not necessarily be within the control of the developer. And because of that, we've said that a developer may indicate that these source attributes are unavailable or they may leave them blank. We do not require developers to externally validate, but we think external validation is a good idea. Therefore, we have the fields, but those with asterisks are not required. So what we're thinking, the concept is this information is well within the FAVE's use. In the absence of this information should be a signal, and we also have requirements for those fields to be supported. Next slide, please. So let's look at additional clarifications on developer supplied predictive DSIs. Pardon me. While the program identified defined input fields for predictive DSI source attributes, it doesn't establish requirements for specific measures or identified specific thresholds for content related to those categories. The program has not established requirements for specific measures of validity or fairness. Again, developers may indicate that the relevant information for specific source attributes is not available nor recreatable. Some examples where this may happen is with the EGFR model. Developers may not have access to the training data that would allow a developer to provide the description of demographic representativeness. In these scenarios, again, developers may indicate that that information is not available and cannot be replicated. Also, another example is for large language models, that may use free text inputs rather than the structured data. Here, a developer may indicate that variables related to race, ethnicity, language, sexual orientation, etc., were not included in the predictive DSI's training data. Next slide, please. So when is a developer responsible for source attributes? And here we have a little animation. This is our NES electronic health record developer. Perfect. NES HeartWatch is a DSI that's developed by our developer. And then next. And the second here, the Zelda is the third party that is part of the NES EHR. And one more. So you'll notice here, the predictive DSIs that are authored, developed, or supplied by certified health IT developer are subject to our ONC requirements. And then down at the bottom, we have Konami's contraindications model that's made by a third party for NES EHR. So a developer does not have to actually supply predictive DSI. They do need to make room for the predictive DSI to be certified. Just a little graphic there. Perfect, thank you. Oh, yep. So some other examples of the supplied by configurations. This has also been the subject of many questions we've received within our JIRA portal. The regulation text says supplied by the health IT developer as part of its health IT module. That would likely include developers who offer their customers, they can either purchase or use, say, the hypertension model. Developer includes a publicly available predictive model like LACE Plus or the Apache 4 as part of its certified health IT product. If a developer incorporates an other party's large language model or other generative AI that meets the definition of predictive DSI and is part of what the developer offers its customers. Supplied by does not likely include apps available through a certified health IT developer's app store. Next slide, please. Access and modification of source attribute information. So the program has established a set of 4 capabilities that health IT modules must support. They must allow or enable a limited set of identified users access to complete and up-to-date plain language descriptions of source attributes, enable limited set of identified users to record source attribute information, also that same limited set of users to change source attribute information. And then number 4, health IT module must indicate when that source attribute information is not available for some source attributes related to external validation, local testing for validity and fairness, and continued assessments of validity and fairness. Again, developers are responsible for updating the information related to these source attributes if it is generated or becomes available with that developer's knowledge. Next slide, please. So some additional clarifications on access and modification. A subsidiary of a developer that develops a predictive DSI is the same as if the subsidiary were the certified health IT developer. and therefore subject to the same requirements as a predictive DSI supplied by that developer. Again, developers must provide the functionality to enable access and modification to source attributes, but are not responsible for the content that may be recorded, changed, or accessed by users. Must enable users the capability to populate source attributes for predictive DSIs that are self-developed by customers, as well as the capability to populate source attributes for predictive DSIs developed by other parties. Again, the developers are not responsible for the accuracy or use of source attribute information that is modified by their users, but rather they are required to have health IT modules that support the capability for their users to author or revise source attribute information. Next slide, please. So organizational transparency on risk management of predictive DSIs. So here, the intervention risk management practices must be applied for each predictive DSI supplied by the health IT developer as part of its health IT module. In addition to information on performance and quality, we also finalize that developers who supply predictive DSIs as part of their products need to apply risk management practices to their predictive DSIs. We relied heavily on the NIST AI risk management framework, and we emphasized a need for data governance, which we describe as policies and controls related to how data are acquired, managed, and used. The program does not require developers to review risk management information for other parties, nor that developers include risk management information from other parties as part of the documentation requirements. Next slide, please. Some additional clarifications on intervention risk management. We weren't prescriptive about the use of a particular framework or standard or best practice. We have applied substantial flexibility in those practices that developers can use to apply to the predictive DSIs. We also allow that developers can apply different levels of rigor to the risk analysis, risk mitigation, and governance of the predictive DSIs. Again, developers are not required to review the risk management information from other parties or include that information as part of their documentation. And again, developers are encouraged to review the NIST AI RMF governed section 6. Next slide, please. Principles of proper conduct for ONC ACBs to ensure intervention risk management, documentation compliance. Here, summary information for IRM documentation needs to be submitted to the certified ONC ACB, and the ONC ACB must review this information before issuing certification. We are cognizant of intellectual property, therefore the developers do not need to include public disclosure of specific information on code, model tuning, parameter or hyperparameter selection, or details on how individual input or output variables were selected or operationalized. This requirement does align with existing guidelines for API documentation. And the policy also gives developers flexibility to determine the information and the level of detail that is useful to inform potential users of whether a model is faves without providing information at the level of detail that might constitute proprietary information. Next slide, please. Safety enhanced design and our DSI criterion. Again, this is another concept where we've received quite a few questions regarding safety enhanced design. So as we mentioned earlier, the DSI criterion is a revision of the A9 CDS, Clinical Decision Support Criterion. The program expects that developers may use or resubmit SED testing from A9 for their B11, and that entirely new safety enhanced design testing may not be necessary in all circumstances. Our recommendation is that the certified health IT developers assess their user-facing functionality gaps and, as necessary, update their SED. Developers will need to publish the updated SED information to the chapel to incorporate into B11 when seeking certification for B11. Next slide, please. Assurances, maintenance of certification requirements. Excuse me. So several source attributes are intended to provide users information on how the intervention performs in local data. This is both because models and data used to drive predictive DSIs will change over time, and because bias and inaccuracies are likely to appear after a predictive algorithm is deployed. If developers do not continue to keep source attribute information up to date, this could have adverse impacts on user trust, accuracy, usage, and safety. This maintenance of certification requires them to keep such information updated to better maintain the integrity of the decision support interventions. Next slide, please. And we're getting close to the end. I think this is one of our last slides, implementation timeline and requirements. This slide sort of highlights what our three categories of folks need to do. For health IT developers, you'll have a year to update certified health IT support capabilities to B11. You'll need to provide that technology by December 31st of this year, 2024. Developers will need to provide summary IRM practice information to their ACB before December 31st of 2024. Developers also need to keep source attribute information, risk management information up to date as an ongoing maintenance of certification requirement. They will need to include this as part of real-world testing plans and results. Additionally, there are implications for our providers, more under the purview of CMS. But as of their 2025 performance period for CMS payment policy, certified health IT will support providers' ability to select both evidence-based and predictive DSIs. And then, of course, the industry. The 31 source attributes finalized offers an industry-wide baseline from which more detailed model cards and other industry consensus can be formed. The transparency provisions are likely to incentivize the creation and support of fairer, better validated algorithms in healthcare. Next slide, please. Perfect. So that's our presentation. It looks like we do have some time here at the end for question and answers. Please feel free to use the raise hand functions and we can unmute you, or if you have other questions, obviously, after this, you can submit your questions to our JIRA portal.
Yeah, thanks, Nikki. And I would also say that we've been trying to answer as many questions as possible in the Q&A box. So if you'd rather type out your questions, we can try and answer those verbally here. And I will also note just a couple other programming things to be looking forward to. We will be having kind of an educational series over the next several weeks, over the next couple months, really, where we will try and maybe provide more focused presentations and create longer space for Q&A on specific topic areas, areas where we're receiving a lot of questions, or areas that we just want to make sure people understand clearly. So be on the lookout for kind of announcements soon on when those dates will happen. We presented to the Health IT Advisory Committee earlier and last week, and I anticipate that we will be doing these educational sessions, one probably in July, one in August, and one in September. We will, of course, be promoting the time and date for those widely. And so this won't be kind of the last chance that you get to ask questions, or obviously, I don't know if you can see the Health IT feedback and inquiry portal is also an excellent way to get in touch with us with questions. So last but not least, I will note that we will likely try to include a transcript of the Q&A when we post these slides. That way, for those of you who've been asking questions or following the Q&A answers, you'll have a place to go back to and find those. So I do see one question's come in on the Q&A box. And the question is, did I understand that US CDI version 1 has to be included in the evidence-based data elements? So the answer to that is the evidence-based support for evidence-based DSI are rooted in a specific list of data elements. Some of those data elements are in US CDI version 1. And some of those data elements are actually in version 3, social determinants of health data being a good example of those. And the requirements to support DSIs based on a data element that is in US CDI version 3 will essentially be aligned with when US CDI version 3 has to be supported. So that's going to be, basically at the beginning of 2026, January 1st, 2026. So for the time period up to and including December 31st, 2025, if an evidence-based DSI includes social determinants of health data and really no other data that's listed in that section of the regulation, then technically the health IT developer does not need to support a user to select that kind of evidence-based DSI. All right, we've got another one here. Does B11 make it mandatory for vendors to support both evidence-based DSIs and predictive DSIs, or can a vendor qualify for certification to the B11 requirements if they only support predictive DSIs? So the answer to that first question is yes, the requirements are that a developer supports both evidence-based DSIs, again, based off that listing of data elements that are in the regulation, and predictive DSIs. So both types of DSIs must be supported. Now, that doesn't mean that a developer has to supply a predictive DSI. If a developer does not supply any predictive DSI, but they still support their users in being able to select a predictive DSI that they self-develop or purchase from a third party, then that's sufficient. So number two, if the vendor needs to support evidence-based DSI in addition to predictive DSI, does the evidence-based DSI need to be supplied by the vendor, or can the vendor simply provide the functionality for customers to integrate and enable evidence-based DSIs that are developed by external developers? The latter is true. Again, we're not requiring developers to supply any predictive DSI or any specific evidence-based DSI beyond drug, and drug allergy contraindication checking. If you're certified to A9 today, you ought to be supporting your clients on drug allergy contraindication checking. That requirement carries over from A9 to B11. But other than that, the developer really just has to support their customers in being able to select evidence-based DSI that are, again, based off those data specified in the regulation. All right, looks like we've got a couple more minutes here, and we've got a couple more questions here.
So Jeff, this is Josh. We have a couple hands raised.
Okay, great. Yeah,
right,
let's take it to the phone line.
Sure. The first one is Luis Palacios. I hope I said that right.
Yes, you did, but I forgot what my question was. So,
well, that's okay. You can go to inquiry.healthit.gov when that question comes back to you, and we'll be happy to try and get to it then.
And next one is Matthew Davis.
Hello, this is Matt Davis with HIT. First of all, thank you for Jeffrey Smith for answering so many questions with some sufficient detail. You answered a question regarding a EHR being not responsible for the source attribute if it was either self-developed or it was purchased from a third-party PDSI. Is there a third option there? So if there's a self-developed and there's a purchase from a third-party DSI, what's the other option where the EHR would be responsible for the source attribute?
Okay, yeah. So the scenario where a developer is responsible for the content of the source attributes are for those DSIs that the developer supplies to its customers as part of its health IT module. So really the only source attributes that a developer is responsible for keeping complete and up to date are the source attributes related to the predictive and evidence-based DSIs that they supply as part of their health IT module. Okay,
and self-developed wouldn't fall into that category?
Sorry, yeah, and self-developed, we generally are referring to self-developed as those DSI that are developed by the customer themselves rather than purchased from a third party.
Got it. Okay, got it. Makes sense. Okay, thank you.
Okay, yep. Okay, it does look like we are at time, but I do see, but we do have a couple other questions here that I can try and I don't know if I can try and answer those after we've ended the session, but we have those in the transcript, and we can add those. We can add answers to the transcript. So, Josh, anything else?
Nope, no more hands are raised, and other than the questions that you just mentioned referred to, no, I think we're good.
Okay, well, again, thank you all for your questions and for your thoughtful feedback. Be on the lookout for additional sessions that we're going to be holding over the course of the summer, and we will promote the availability of the slides and the recording and hopefully the Q&A transcript as well over the next couple of days as we get that 508 compliant and posted to the ONC website. Thank you so much, everyone.